This episode of the Cool Beans Pod is brought to you by the hard-working mother and daughter team behind Uma Umu. They make organic cotton t-shirts in Portugal, plus jumpers, hoodies, and button-down shirts for men, women, and kids, all designed in Portugal using organic cotton. I wear their clothing daily, not just on the pod, because it's really great. You can catch Uma Umu on Instagram and at Largo Market in Porto. Cool people doing cool things. That's Uma Umu, Cool Beans, and the Cool Beans Pod.
My specialty is always on a red line. You are always on a rush to save people, to decide under high pressure circumstances with limited information. You have to take big decisions. And I was okay with that. But COVID took me to places like that. I think I have some trauma.
You crossed the line
Yes.
on a personal.
For example, things like deciding who to take to intensive care when you have one bed and you have 8 proposals of patients, so you are not doing well, and you can't take them all because you don't have the capacity to save them all.
So I was wanting to improve my Afrikaans, and I was listening to some apps. Afrikaans is a language we speak in South Africa, and I was downloading some apps. Beg your pardon, some podcasts. I was searching, and I found a few on Apple Podcasts. Mind you, I should have maybe looked at Spotify and a few different places, but I found a few, and most of the Afrikaans sentences that they would speak in the podcast contain so many English words, because a lot of Afrikaans people were living. They live abroad, and they would meet once a week, and they would make this podcast, and they put it. And I was like, if they can do that, then I can make a podcast, right? And then I had a hernia operation, and I actually got it diagnosed up at Pedro Hispano, where you are, which is a very, very interesting story about being observed. But I'll save that one for later. And I had a week off of the operation, and that's when I just sort of fiddling around. Right. So everyone's here about the Cool Beans Pod. Thank you very much. We are rolling, and we have Elena. Can you say your surname, please?
Molinos.
Molinos. That means Elena Windmill, right?
Yes.
Windpomp, as we would say in South Africa. Thank you so much for joining us on the Cool Beans Pod. You are our first medical doctor. Okay, so we're very excited. Well, I am very excited to ask you a few questions. And you work in the public healthcare system here in Portugal?
Yes.
Yeah. Is that close by? Where exactly do you work?
I work here in Pedro Hispano Hospital.
Pedro Hispano. So if you're from Matosinhos or Porto, it's just up the road. And specifically where?
I work in the intensive care.
Intensive care. Okay, cool. So that's basically people that are very sick.
Yes.
And they need specialized healthcare.
Yeah.
Okay, brilliant. And how long have you been over here in Portugal?
It's 23 years.
23 years. Right. Your husband is Spanish or Portuguese?
Portuguese.
He's Portuguese.
My second one.
Your second one.
And my first one.
And the first one. Third one might be Spanish. Okay, brilliant. So you live over here in Matosinhos, and do you like it? You enjoy living over here in Portugal?
Yes.
It's good.
Yes. I come from the north of Spain.
Oh, the north. Okay,
Galicia.
Galicia, beautiful.
I was born on the other side of the border. Near here. Yes. So I know Portugal since when I was a kid.
Okay.
And my parents and I used to travel and to Portugal. I had some friends, so we were neighbors. There's a cultural proximity with Portugal.
Yes.
When I came to Portugal, it didn't seem to me that I was going abroad, but I was, because it's really a different country with a different culture.
Yeah, the culture.
I felt some differences between Spain and Portugal, but I enjoy a lot being here.
Especially up here in the north in this area, right? Maybe not now with the cold and the rain, but overall it's great. It's always interesting for me to meet Spanish people that live close to the border, or Portuguese people that live close to the border, because they do eventually. So those of you who don't know, we have open borders, right? Because of the EU, the Schengen, freedom of movement. And a lot of Portuguese people that live on the border go to Spain, and a lot of Spanish people that live on the border end up going, the concept of the grass is greener, isn't it? So the Portuguese people go to the Spanish side, and the Spanish people go to the Portuguese side.
If you go to Vigo during the weekend, it's full of Portuguese.
Where Vigo?
Vigo.
Yeah, Vigo's lovely, isn't it?
Vedra and south of Galicia is full of Portuguese. And during the summer, they used to go there to the beach, and you go to the towns on the north of Portugal during the weekend. You'll find a lot of Spanish.
Yes.
Had a ranch.
If you go to IKEA on a weekend, you'll find a lot of people, Spanish people in IKEA, won't you? They do like it, yeah. But we have a cousin that lives up on the border. He's Portuguese, but he watches Spanish TV, Spanish cowboy films. So that's how he learned how to speak Spanish. Yeah. So thank you very much for. You were a bit nervous. How are you feeling now? You feeling all right?
Yeah.
You settled in? Okay. So I got a few interesting sort of discussion points and things I want to talk about the healthcare system in Portugal. Lately, the SNS has been under a lot of scrutinism. There's been a lot of inquiries into what's happening in the ENS. What's going on there? Why do we have the waiting periods in the healthcare system at the moment in emergencies? Do you have any insight into that?
Oh, well, I think it's like many other things. It's a quite complex issue. I think probably it's not just a Portuguese case. I think healthcare is in crisis everywhere. At least that's the feeling I have, because today with social media we can communicate with access to information about what's happening in many other countries. And I follow different doctors in different countries, and it seems there's a spread sensation of tiredness and not recognition of very hard work.
Bit of fatigue. Yeah. In particular amongst the nurses, right?
Yes, nurses and
doctors.
And doctors too. We are burnt out.
Of course. Do you think COVID had sort of COVID was a bit of definitely was an inflection point for society and civilization, but do you think that was a marked moment, and then it's just we haven't really recovered from that? Because a lot of teachers burnt out during that time because everything had to go online. But from how do you think that was a bit of a seminal moment?
For me, it was.
It was for you.
In my personal experience, it was very important. I just want to go back again, and that one of the crises comes from the fact that the population is aging, and the demand for public care is for healthcare is increasing, and
so you have more people that are older.
Yes, and
they need specialized care.
A lot of healthcare during the last years of their life to live enough or to live well. And medicine has changed a lot in the last decades with the internet and the digitalization of everything. Information is running much faster. So I remember 20 years ago when you had a difficult case, a different situation, a difficult diagnosis. If you wanted to study, you have to go to the books or go to the library and ask for scientific papers and read, and it took you maybe some days to discuss to another colleagues. But now, in the last years, you open the internet and you have the answers immediately. Yeah. So medicine is got much faster
and more effective.
And more effective.
Yes.
Of course.
So more people are staying alive for longer.
You feel more pressure, and healthcare is getting better. So, as people gets older, they accumulate more illnesses before they die. So we live quite well with a few illnesses. So a few years ago, when you had to assist a patient in the emergency department, the amount of problems, of clinical problems a patient had was much lesser. I mean,
It's much less than now.
yeah, there was. Today you have to assist people with a lot of different health issues that interfere one with each other. So
And that is because they're living for longer,
yeah,
and these
things
issues are
it's
coming together.
yes, and it's more difficult if you have to if a patient has to go to the operating room because an hernia.
Yeah.
It's very different if it's a 40-year healthy man than if it's an 80-year male
Because there's
diabetes or a stressor disease and a pulmonary disease. But you have to calculate. Medicine has to be very precise.
okay.
Okay, so it's more stressful, requires more from us, but we have less time to see more patients because we have more people coming.
So you've got to spend less time with a patient.
Yes.
And I know that public health, not so much the ones where I've been going now, but I know that in private healthcare, you often feel like it's a bit like a factory.
Yeah.
Right, so you go in and it's like they got 5 minutes or 10 minutes with you, and then it's next, and then it's next, and it's next, and then you have a ticket and your name appears on the screen. I remember growing up, and you would go to the family doctor down the road, and you would probably be there in an hour, and for an hour, and he'd be chatting about all sorts of things about the sports match, and all the sorts of things, and you don't get that anymore. I have found a few doctors, I will tell you that. I have found a few doctors at Luzia this year in Porto that definitely have that old school vibe where they still sit with you, and they have that conversation, that holistic conversation about your diet, about your exercises. But obviously for you in the public system, it's a bit difficult, right? Because you have all these people you need to see, right?
Yes, and then you have to write a lot.
You have to record your
There's
observations.
a lot of work outside the conversation with the patient.
There's a lot of work outside the diagnosis.
Yes, if I talk to you, if I speak with you for half an hour, I have half an hour of work just writing, registering,
Okay.
asking for exams.
You see, so sometimes we don't know this as patients. We don't realize this.
Patient.
Yeah.
We have 20 minutes for patients.
Is that the standard, 20 minutes?
Yes.
Okay.
It's I think it's in
And if they're
you have 20 or half an hour for that if it's the first.
okay. So that means, say, 30 minutes then ends up in 30 minutes of admin work. Have you ever extended an observation or a consultation because you really like the person, or because you see it? Well, you see like a really handsome man. Because I think if I was a doctor and, you have the pretty ladies coming, there'd be like a 2-hour consultation, right? I'm just joking. Not really. Intensive care doctor. Okay, what is that specifically, and how does your day look from morning to night? So when you wake up and when you go home, tell us about your specifics and then your day.
Okay, so in intensive care in our hospital is a unit with 14 beds.
14 beds, okay.
So we have patients who need immediate care because they are in high risk of dying.
So there'll be someone in an accident that's just been in an accident.
We have like strokes, trauma, myocardial infections, severe infections, sepsis. So we have a circuit that starts in the emergency room. In the emergency department, we have a special room for the
Severe cases.
severest cases. Okay, they are triaged in red. So it's
They're labeled red.
life-threatening condition.
Life-threatening condition, okay.
And we assist them there, and then when
They're stable.
then when we stabilize them, we take them to the center and we treat them as well as we can, and then we discharge them to the wards.
To the wards, okay.
And then we have a system of follow-up of our patients. We followed them up in the wards, and 3 months after discharge from hospital, just to address the consequences of an intensive care experience, both for the families and the patients.
So there's like a follow-up on, and like a survey.
We have a structured follow-up, like consultation with.
And does that data then feed into creating better practice going forward?
An investigational project.
Okay. All right.
Linked to that. So we gather that data about the processes, and then we study it. So there's a lot of people working. We have 14 beds, and we are around 60 people between.
So how many doctors nurse ratio?
Doctors, around 10 seniors, but we have juniors from intensive care and juniors from some other specialties that goes through their learning pass through.
So they're doing their rotations.
Yeah.
They're learning.
Intensive care, and we have a lot of nurses and nurse assistants, and then we have some collaborations from other specialties like infectious diseases consultants.
Okay, yeah.
Psychiatry.
So people you can consult with with a particular, like there's an infectious disease and you need a bit of help. Okay.
So we work around, between 60 and 80 hours a week.
So that translates to how many hours a day? You do the maths because you're the doctor, right?
Yeah. It depends, but a normal schedule is about 60 hours a week. We have 1 24-hour shift per week.
Do we still do that? I didn't know we still do that. That's absurd, right? I mean, that there's no way someone can function like that. Unless you're buzzing on Monster Energy drink, caffeine. And what is that thing they take?
Doing that for 20 years. And
so you're okay with that?
No.
No.
I'm finishing a leave sick because I burned out.
You've been on because of burnout, because of that nonsense.
Because of.
We had a situation. We had a terrible situation in South Africa. Sorry, just to jump in there, but a young girl had just finished studying to be a doctor, or she was in her final year, or she just started working, I'm not sure. And she was one of multiple cases, and they were doing these 24-hour shifts, like once a month or once a week, I don't know. And she was driving home, she crashed her car.
Yeah.
Because she'd worked for 24 hours. In fact, she'd worked 26 hours, and that was the other doctor ended up being late, or was caught up in she was caught up in an emergency, and they had to do a massive investigation. And only then, that's the world, isn't it? We first mess up, and we first have to feel, we first have to feel the pain before we change. So 24 hours, that's absurd, right? You agree with me? There's no way you can make the right decisions.
Yes, you can, but you can do bad decisions.
Do some nice, you can. And in your case,
when you are 20, 30, 40.
You have the energy and the will and the passion.
I'm 15 hours, and it was too difficult for me to work
24 hours. That's mad.
Especially after COVID.
Yes. You could have just tried ketamine, because I know in America
we have there.
You could just smash a bit of ketamine, and then they work like 48 hours in Silicon Valley. No, really, those coders, that's what they do. That's why we have X and Instagram. They've all been high on ketamine. So when are you going back? Or are you already back at work? You're going back next week, and how are you feeling about that?
Fine, because I've made a complete shift in my career.
Okay.
So I'm not coming back to the intensive care.
Okay.
I'm going to a new department.
Which department are you going to go to?
Research.
Oh, nice.
Innovation in healthcare.
Okay, which is nice, because I've got a few questions here about AI. Right? So we can not just chat GDP, right? Or chat Gemini or Grok or WebMD AI. Okay, so you're going back. So tell me an average day. How does an average day look for you? So you've got the 24 hours. Yeah. So what, 6 a.m., 7 a.m., depends, right?
It's 8:30 until, it depends. The official hour is 4:30, but sometimes we stay a little bit longer.
Yeah.
And the day you are in charge, you have to, you are in charge of the unit. You are the
supervisor for that period.
You organize the unit, so we all starts in a round when the colleague that work during the night explains to all the team.
There's a handover.
Yeah, it's
They have to hand over the cases, and then you come in. So if you're doing the day shift, yes.
exactly.
Okay.
And the plan for the proposed plan for each patient. Okay. And after that, you have to organize the team and distribute work for normally youngest doctors go and assess patients and
Make notes.
with notes and and they come to you back to reorganize.
They give you the feedback, and then they offer some advice. And do you enjoy working with young doctors?
Yes, a lot.
Nice to see the next generation of doctors coming up. Have you seen a difference in work ethic?
Yes.
What's that difference? Because I'm in education, and I see a big difference in work ethic with younger teachers, good and bad. There's a good element to it as well. The Gen X, right? The boomers, the one before, and then we've got the Gen Zs coming through now. What have you seen in terms of training and the doctors coming up and the difference in their work ethic?
Well, they are very well prepared.
Okay, so there's a good element there.
Yes, there are some very good elements. They are very well prepared, but they don't have the same mindset we feel in terms of commitment with work, and that's sometimes we feel it as a bad thing, but it's not, because this it's, for example, for my generation, it's and the boomers, it's supposed to be that being a doctor is being a person in continue working all the time, or always committed to work, and
It came first. Work came
yes,
first.
work comes first.
Even if you weren't a doctor,
And life and your life
came second. Yeah, absolutely.
and we are used to see it as a normal thing, but it's not. It's not.
No, it's not. It's not. I think they're right.
That's why we get ill, because life is not just work.
Yeah, the body keeps score, doesn't it? You know that brilliant book, The Body Keeps Score, about how you have the years and years of stress and work and all this, and then it piles up. And the new generation are a lot more balanced in terms of they go play games and so on. I always wondered, how, like, for example, you have kids, you have children, right?
Yeah,
you have, how many children?
16 years.
You have a 6-year-old. As a doctor, how often do you get to be with your child? Do you see your child? When do you see them? How does that work then? Because this generation, they're going to be a lot better in terms of
Yes,
spending time with their children.
I guess. So to be a good doctor, you have to dedicate a lot of work. It's a very complex profession. It's difficult. I mean, but you don't need to give your life away. It's not balanced, and I guess I'm learning from the new generation. Something that I always felt, because since I started working as a doctor, I felt it was too much. But you go into a system that works that way.
So you just fall into the system.
Yeah.
That's the narrative, and you just follow the narrative.
Yeah. But I've never felt comfortable, because I always find it was too much. And anyway, I gave everything, because I felt, or I feel substantial part of my personal life
Suffered.
a lot was my kids' grandma that raised.
That raised them, yeah.
She knows where he said the first words. She knows where he left the diapers. She knows where he ate the first soup.
And how do you feel about that?
I wasn't there.
And how do you feel about that? Is that difficult for you? Because now the child is 16, right? It's a boy, right?
Yeah, it's a boy.
The boy.
I'm okay. I'm in peace, because I can't change that.
Yeah.
And
It's an uncontrollable. There's nothing to do now.
yes, I can't change the past. I can't change the future.
You could have another one and try again, yeah? And then you're still young enough.
No, but at the end of the day, I love my son, and of course, I like him a lot.
Yeah.
And I think he's a very interesting boy.
You can love them and not like them sometimes, right?
And he's a good guy. He's very interesting. He studies a lot. It's a very good. I don't have problems with him.
Yeah, but there's always that element that you weren't, you weren't there. But that's a choice because it's in many careers. You can't be there. You say yes to one thing, you ultimately saying no to another. That's probably what this generation, the younger generation, doesn't understand, is that there are sacrifices you're going to make, even if they're just for short periods of time, where you are going to disappear. They call it now, I don't know if you've heard of it, ghost mode. Have you heard of ghost mode? So you ghost someone, so you don't message them back, but it's called ghost mode. And that's when people are ghosts for 6 months, and they go to the gym, they eat healthy, and they just work on their career. But the Gen Xers, you guys went ghost mode for decades. Yeah. They do it for 6 weeks, and then they think they're meant to run Microsoft, And I think, yeah, it's interesting talking to a doctor and to see that how vulnerable you are with that information, because it's tough, isn't it? Because I have a 5-year-old, and I'm thinking, I've been there with every single journey because I'm a teacher. I'm a teacher at the school he goes to. So I see him at break time, I see him at lunchtime, I see him walk, and it's amazing. I love it. And it would be difficult for me. But you've dedicated yourself to a profession of care, and you've saved a lot of lives. You've obviously provided care, and you've given mums, you've saved children so that they can be together, which is also a very beautiful thing. So that's difficult. And now that you're going back, how does your research situation, your new posting, your new position, does that give you a balanced, bit more flexibility, a bit more time to be with your family?
Yes, because I have night time. I'm not working during the night anymore or during weekends. So I have a regular schedule.
Oh, you're gonna love that, hey?
And I'm going to be able to work on remote.
Oh, nice. So in your pajamas.
Yeah, so I think my life is going to be more balanced.
Okay. Tell us a little bit about that research, and then I want to jump into some AI questions. What research is it going to be?
I still can I don't I can't tell you many things because I'm new. This is a new field for me.
Okay.
I've also,
So we can have you back in 6 months. You can tell us about all of
and
that.
I'll tell you our projects, because I have always done some research in clinics during my career.
That's part and parcel of being a doctor. There's always an element of research, isn't it?
Yes. It's not just addressing or assessing patients.
Yeah, you do a lot of research.
Researching in organizing the unit, in improving quality, in organizing processes, and it's in
And that's sort of
teaching other doctors and research.
And that ad hoc research you'll do, spending not so much now with the internet and computer systems and AI, but you would spend a lot of time in your books at night time, looking at case studies, looking at treatment plans, right? Patients, there's always a patient that, you're thinking about, or treatment plan, right? So doctors is research, right? Being a doctor is
It's like
constantly
being
research.
like a Sherlock Holmes.
Yes, exactly. Yeah, investigating all the time. Or Dr. House, that's a famous one, yeah. They like to say that, unfortunately.
It's a very nice profession. Being a doctor is stressful. It's difficult, but it's always very rewarding.
Rewarding, I imagine. Because you're saving a life. You're saving a life, and you're changing someone's life, and you're improving their life.
Yes, and you meet a lot of people. You know a lot of different people in stressful situations. So it's like a journey through humanity, because you have to deal with a lot of disgraces, with pain,
Loss, suffering.
yes, of course, and it's like reading books. It's like traveling without going anywhere, just watching people's behavior,
Losing a mum or losing a child
to observe
at their most vulnerable,
yeah.
at their deepest and darkest period in their lives. You're there. And also at period when there's the highest elation they would ever feel, knowing that you've saved someone. It's a very
Many times it's about dealing with death. That's a very important part of our work.
Especially when it's a child, right?
Yeah, I don't work with
Children, no?
children. We just have adults. But sometimes we have very young people that is.
And having to go out to a mom and dad and
Yes, yes. Not in our hospital. We have a lot of adults. But I've worked in other units where they had trauma, head trauma, and a lot of young people dying or having brain damages.
Can you
And working with parents suffering a loss or the fear of losing a child is is one of the worst cases. Having to give a
deliver the news? That's what I was going to ask. Yes.
the death of a child is devastating.
Yeah.
It's always bad, but
Yeah.
for fathers, for parents, is horrible,
Yes.
and it's very difficult.
And what prepares you for that? How do you prepare for that? Is there training? Do you receive training as a medical student, or is that just experience, guidance from older doctors, mentors?
I didn't receive any training. I think now medical schools are different now, and they have that kind of training. But we didn't. We just learned as we could and studied.
You watched the older doctors, how they did it.
Yes, and learned how to do and how not to do. You learn a lot of things.
How do you not do? Sorry, can I ask that? How do you not do that? How do you not deliver that news? What is the one thing you don't do?
I never lose respect for patients, and I always, and for families, I always try to put myself in their shoes. And when I was younger, it was easier to
Deliver the news.
yeah,
And then you had your own child. Separate.
separate things. And as time goes by and you get older and experienced, it goes more difficult to
Because you know the price of life now.
create that barrier in which you can feel, or you
It's more difficult not to feel the effect of it.
yeah.
You would think it would be the opposite, isn't it?
Sorry?
You would think it would be the opposite, wouldn't it? You think when you're young, you're very impressionable and it's difficult. And then as you get older, you kind of get hardened and your skin gets hard and you're tough, like mutton. No, interesting, eh?
It's not.
Interesting.
At least for me, it wasn't.
You might get better at delivering the message and dealing with it with a very difficult and delicate situation, but it has a much bigger impact on you, and you take it home and I don't think we realize.
And we cry a lot.
So do I at school all the time.
We turn back and we cry. You can't do it. You can't do it when you are with families.
Yeah. But you need to go find a space to get that outlet.
But sometimes you can't control yourself.
Yeah. It's just a normal human emotion, isn't it? It's normal.
Yep.
It's normal, yeah. Yeah.
And sometimes it's even useful because.
Oh, yeah. Getting a good cry out, you can do your work after that, you feel better.
And for families, because they are watching.
Or they see the connection.
Yeah.
Okay, they see the doctor crying and they're like, okay.
Or maybe not crying, but
Visibly upset.
yeah.
Okay. But obviously when you were young, that's not something that might have happened. And as you got older, you became a mum, you're a wife, and
Being a mum
it changes everything. It changes everything, doesn't it?
changes everything.
Yeah.
I remember the first time I had a kid, because in the emergency room sometimes we have pediatric emergencies, and we have to deal with them, but it's not supposed to be to happen, but sometimes they appear. And the first time I had to go there because of a toddler with convulsions.
Convulsion.
With epilepsy.
Okay, epilepsy. Okay, convulsions. Yeah.
And most of the times they are febrile convulsions, it's just because they have fever.
High fever.
And it's not.
Febrile convulsions. I'm trying to upskill my medical talk here as well.
And the first time I had to assist a toddler like that, I got so emotional, and I saw the mother, I saw the kid. The mother was terrified. The kid was crying, and I for a moment I got stuck, like couldn't.
You froze. You froze.
Frozen, and then I reacted, and
Your training kicks in, and then
yeah.
I wanted to ask you something about the God complex, right? Where you become so good. I hope I'm using it correctly now. I don't know, but some might correct me. But the God complex is, as I understand it, you become so good at something, you believe you are a demigod, or you're invincible. And I know a lot of surgeons, a lot of really vascular surgeons, cardiac surgeons, those type of guys, a lot of them eventually develop this God complex where they're just so good at their jobs, and they know that they have all this power, and they have this. Have you worked with doctors where that are just unbelievably good at their jobs, so incredibly precise, so incredibly accurate, but they have this level of arrogance and this bit of God complex? Have you had experiences like that? Because I don't pick it up in you. You're very humble, you're very down to earth, you're very honest about your experience as a doctor, but have you dealt with people like this? And tell us a little bit about that.
I'm trying to imagine to put a face in that person, but I can't.
I say so because I have a story from my family where a doctor performed an open heart surgery on a member of my family, and it saved him somehow. He shouldn't have, not shouldn't have, but the situation was quite dire, really bad, and he was rushed through, operated on, open heart surgery, and relatively youngish doctor compared to this particular family member. And the doctor, a week later, this particular family member said, "Listen, thank you very much, doctor, and thank you, God. Just praise God, thank God." The doctor said, "No, it was me that saved you. I saved you." Right, and it was. Yes, but
But let me just say that most of the families, when they come to recognize work, thank God, or here in Portugal is thank to the Virgin,
Mary Virgin, Mary the Virgin,
and doctors.
and doctors, of course, and the doctors. Yeah.
And I've never said, "Oh no, we saved him."
Yeah. But you see, you get that.
But that's very usual.
But the medical practice needs these people. I'm not saying they do need them. Look, can we jump into a little bit of AI? How is AI currently being used in healthcare in Porto? How is AI being used? Do you know how it's being used in the public now, in your experience?
I'm not sure I can answer that question.
I'll tell you what.
It's very broad
Because
I don't really know what's happening in Portugal or in Porto, but
globally,
what I can tell you is that it's spreading the usage.
it is spreading, but very low, because the OECD report from 2005 says globally 80% of hospitals globally use it, compared to 9% in Portugal.
9?
Yeah. Those facts are verifiable. That means there's a very slow and moderate adoption rate over here in Portugal. Obviously, the main concerns here in Portugal with AI uses are training errors and just general low exposure to it. But is there resistance from doctors to use AI? Are they open to it? What are your experiences with AI in the medical sphere?
It's a little bit like in the rest of the society. There are early adopters.
The late comers, the laggers, yeah.
So I know some doctors that are really early adopters, and they and I try to learn from them. And I guess the youngest generations are adopting AI more easily. But I think that there are two levels. One is individual usage of AI, and the other one is institutional usage
of AI. That's a very good point. Yeah, that's a very good point.
I I think maybe that report refers to
Institutional. Yeah, it refers to the global adoption across hospitals. Yeah.
because I think doctors are adopting it, and maybe the oldest ones are more
Resistant.
resistant. It was my case. I mean, I discovered LLMs. I was not an early adopter. It passed 2 years since ChatGPT was in the market when I discovered it and I started to use it. But I guess the usage of LLMs and tools uh, for
Diagnosis.
not just I don't think we doctors use it for diagnosis.
For
I
analysis.
use it
So we say for analysis.
to get uh, to access to information in a faster way and for example to when we say the diagnosis I mean if I have a patient in the emergency department, I'm not going to ChatGPT and say, "Oh, I had a,
Of course not. No, no. Because you can just use Google for that, right?
with a back pain. What's the case?"
That's what I do in the mornings with my back pain.
But I would go and ask, "Oh, I have this patient with an infection, a renal infection, and I have to give her an antibiotic, and she's allergic to penicillin." And the answer is, "Can you use this one?" "Oh, yes, I can, because I know I can. I don't have to think about it."
No, I think the adoption is predominantly around two areas that I've looked at, that I've done a bit of investigation, because I've looked at it a lot from education point of view because of being a teacher, and then I've looked at it from a medical point of view, is analysis of results. So AI now globally, not so much here in Portugal, but is they use AI to analyze your results, so your blood tests, scans, X-rays, anything that, as you said, institutional level. So anything that's you've done a test, a scan of some sort, it's run through a LLM, and it will give you certain results according, and then the sources. Okay, so for example, ChatGPT or Grok or Gem, I think Grok might, but Gemini, they don't give you the sources. Whereas Perplexity, which is a really, really good LLM, you might want to pivot to that one actually, because ChatGPT is very much outdated. I think, yeah, yeah, there are a lot better ones. But so they use it for analysis of results, and then the doctor would get that information, and then the AI would then disseminate the results and then send you to the appropriate department. So the blood test would be captured, and then it'd say, okay, now you've got this. So I'm going to book, the AI books an appointment at the the oncologist or wherever, right? So this is where they. So it's not really diagnosis. It's in, you're sitting here and you're going, okay, right, you're 50 years old, and okay, let's see what the result is. No, I think that won't happen. I don't think that's gonna.
It's more like about workflow.
Exactly, workflow. Exactly. Yeah, you're gonna call the hospital and they're gonna say what's wrong, and then the chatbot is gonna use the information. Automated. Yeah.
Many processes that don't really need on a human.
Exactly.
Yes, and it's
Well, we could have robots on triage as well.
Unfortunately, with has a project with kind of workflow in cardiology. It's like you have a result, and the result you have a certain exam, certain result. That certain result, if it's positive,
Goes that way. Exactly, the workflow.
Another exam or a consultation with a specialist or whatever.
And that's what you're referring to when you refer to workflow. Interesting enough, it also helps. So again, I looked at it from a teaching point of view, and then I looked at it in other working areas. It helps many professionals, including doctors, to construct reports.
Yeah.
So it's helping many workers to take, so for example, you have these notes, you've seen 50 patients. You can scan those notes, right? Take a photo, you can scan them, run them through an LLM, and they can type out.
There's some better than that.
Oh, even better,
Yeah.
you can record it.
Yeah.
You can record it. Yeah, exactly.
Yeah, that's
So imagine how much time you're saving then to then that you can spend on your patients, face to face, human contact.
that
Yeah.
software exists.
Yeah.
It's commercialized.
Yes.
And it's just that you sit with a patient with a microphone.
There you go. Even better.
You
than
have
that.
your conversation, and AI is doing the registration.
It's capturing all that information. It's feeding it to an LLM. It's amazing.
It's crossing the information.
Amazing.
Because it's taking your conversation and it's crossing information with the patient's history. So at the end of the consult, you have a report with a summary of what happened,
And it's written in your style.
proposed diagnosis, and proposed investigations, and the doctor just have to spend a few minutes checking if
Yes, you have to.
information is
To
okay.
making sure it's correct. And you can just go rephrase like we do at school.
And there's also investigation around that kind of software.
Okay. So you're going to get involved. In
Measure
that.
how many times they really do a doctor really earn. And I've read about some investigations, and they were quite disappointing because it's about it's 2 minutes, 2 minutes per patient.
2 minutes per patient. That sounds like Kuf here in Porto. In Kuf, it's 1 minute a
But I
patient.
think that's an ongoing work.
Yeah.
I guess all that AIs are in training, are evolving, and
They're just getting better. There's so many millionaires that are going to be made from AI.
Yeah.
I think it's
I think
bigger than the internet.
The great disruption of AI in healthcare is not. It's going to be in workflow, but the great disruption is going to be in prediction.
Prediction?
In prediction, yeah, in doing taking all your data and all as the capacity of computation and data analysis is so high that you can introduce data from a population in the AI and recognize patterns and risks. So maybe in a few years you go to your GP and he'll say, "Oh, Gary, you're 50, and we've been analyzing your history, your clinical history, and you have a 90% probability of having a stroke in a few years. Oh, you're having a probability of having a lung cancer in a few years." And I guess that's how medicine is going to work. So we're going to be able to anticipate your personal risk.
So healthcare is going to be
And
predictive.
work in that risk to prevent you from having that disease, especially specifically. So
There are already companies in America where you can go, probably in other countries as well, but I know about one in America where you do a battery of tests, everything. Like they put in all your data, genetic testing, everything, where you've lived, how you've lived, where you were born, everything, your parents, your family, 3-4 as far back generationally as you can. And then you put that all into or the doctor puts it into an LLM, and then it's called predictive medicine. So what they do is they then use that to tell you, okay, this year you're going to do these tests, and then this year you're going to be at risk for, as you said, you may probably going to have because of the exercise you do, you can have a hernia. So maybe we should do a couple of scans of your back and Maybe you should go to physiotherapy. Maybe we should do a bit of Pilates. Maybe you should reduce your running. Okay, so you're 40 now, you get 50. Okay, maybe we're going to reduce the running by 50%. So we're just going to become smarter and smarter and smarter in terms of not
Personalized.
in a personalized healthcare system. So we're going to become predictive, and we're going to predict what. But doctors can already do that. Half of the time, they already know that. They say, well, when you smoke, you overweight, you watch too much Netflix. Well, that's going to happen, and that's going to happen, right? So we already do that, right? And we just don't listen. People don't listen. Do you think they'll listen to the AI? I don't know. Do you think they'll listen to the AI?
No.
No, probably not.
No.
Probably not. Quickly.
Changing behaviors is one of
Change is a fascinating concept. Just the concept of change is fascinating, and how you get people to change
very difficult.
Change is always by invitation. Always. Change. Jordan Peterson said that. One of the Jordan Peterson quotes. Can I quickly ask you, public versus private healthcare here in Portugal, what are the real differences? So imagine you're an expat. You're living in the beautiful South Africa, America. We have a lot of Americans over here now, right? So, and you listen to this podcast, and you're a medical doctor in the public healthcare system, and you're planning to come over here. What, in a very short, succinct manner, what are the differences? If a potential new resident in Portugal, what would you tell them are the main differences between the public and the private?
I've never worked in private medicine, so
So you are a true doctor to the heart. True doctor. Not a koof
I am a
doctor.
public service.
You're a public service doctor. There you go, koof.
So I'm not really.
So you're not well rehearsed.
What happens in private hospitals?
Okay. I'll tell you what. If someone is listening,
I know many things, but I ignore a lot.
would you agree on Lusíadas? They're solid. Lusíadas, we have a couple over here.
I don't know it.
We don't know. Okay. I love how
Because
neutral you are here.
if it's difficult to generate a general opinion about anything, it's always unfair because reality is always more heterogeneous.
Oh no, South Africans generate it quite quickly.
Yeah.
Doesn't take us long.
You can have a wonderful
Experience. It's true. It's true. Yeah.
experience in public health system, as well as you can have a terrible experience.
Or you could have 5 consecutive horrible experiences and then.
It's on a lot of things.
Yeah. No, you're right. And it depends on the doctor, on the day, their mood. You can be in a bad mood. You're right.
It's different from hospital to hospital. It's different from service to service.
Okay. But you know, a lot of people, it's funny, a lot of people complain about the Portuguese healthcare system, and then they leave and they come back and then they're like, oh, it's amazing. What are your views? It is great, the Portuguese. I mean, there are problems like any healthcare system, but it is great. It works.
Yes.
It works.
It works.
I mean, and I can attest that as a parent. And I dropped a shower door on my toe in the summer, and I got an X-ray for 12 euros. Granted, I waited 2 hours and the place really stank. But I got an X-ray and I saw an orthopedic surgeon within 2 hours. I got an X-ray for 8 hours, and I walked home. Great. You know, that's the biggest reason for bankruptcies in the US is because of unpaid medical bills. Can you believe that? The biggest reason people go bankrupt in America is because they don't pay their medical bills. It's not like they don't want to pay them. It's just they need the medical care and then they can't pay them. We don't have that in Portugal. We have socialized healthcare. There are small percentages that you do pay now. I know people, that changed the last 10 years, I think. But your views on it? I think it's great. It has its problems, but it's great.
Yes, and I think it's a great thing we have. And if we are not happy with it, the answer is not destructing it.
Exactly. Well, with anything, is improving it. Yeah.
But that's a general feeling that I have with everything.
Everything in life, yeah.
If you hear to politics and speeches and even people on the street, it seems that everybody needs a change for whatever. So vote for this one because we need to change. I don't want to change. I want to improve. Important change can be changed for worse. So we have to focus in changing for good. So if justice is not working perfectly as it will never work, or healthcare or the educational system, the answer is not to break it down. It's to improve. So, but in improving things is very difficult. It in every field, I guess, from companies, healthcare, teaching, improving requires continuous effort. And when you start doing that effort, things get worse. If we don't organize ourselves, and if we don't, as citizens, ask ourselves if we are helping to improve things,
Are we part of the solution or part of the problem? I think that's fundamentally what it comes down to, isn't it?
and we are living it every day in international politics, and this.
Politics is just a soapy. It's a big telenovela, particularly in the day and age. I mean, it's ridiculous. My son watched Donald Trump talk the other day, and he asked him if that was even a real human being. It's bizarre. And even here in Portugal, when you politicize the healthcare system, you're playing a very disgusting game, because healthcare is a right, and you don't politicize it, and you don't load your political career on changing. You should load it on proving. You know, in the 60s, they got together in the States and they bought in all the airlines. Delta, American Airlines, all the airlines from all over the world. And they said, from now on, we're going to share all the information about our crashes or our malfunctions or any issues we've had in flight. And there was a drastic drop, right? But it was shared under the condition of, amnesty. So they weren't going to use that and then charge you. Okay, so you had the freedom to share, and you weren't going to have any repercussions. Of course, then there you have the airline might have its internal issues where you actually did make a mistake and there might be repercussions. And they applied that to medical doctors. They started applying it. And suddenly, doctors felt safe going, I did this, and this. And they didn't feel they were going to be scrutinized and trialed, charged, etc. Obviously, Europe's a bit different than America, where, you can be charged if someone slips on your driveway, right? So that's what we need here as well. Instead of trying to break it down, let's all get together. Blanket amnesty, and just say, okay, that was stolen, that was misused, that's a mess, that's gone, let's forget about it. Let's blanket amnesty and let's just fix things and make it better.
I don't understand why politics, national
Politics
are not programmed from great consensus. I think it should be obvious for a country that a country has to have a strategy for healthcare, for education, for defense, and that strategies should be discussed and between different parties and get to a consensus. Sometimes you know
which direction you're going.
there are always different interests, but there have to be negotiations to define what is the objective for our country, for education, for the next 20 years. And the most obvious would be to implement the process, and the process goes through 20 years, and the politicians coming, losing and winning elections,
They have to align to that.
They have to follow. They should have
the national strategy.
The national strategy.
Yeah. So
what's the point?
No, it's brilliant. It's your head was wrong. We worked in the Middle East where Qatar used to have the national strategy 2030 or 2040, and obviously they have a ruling class of individuals, right? But everyone that came in, in their quasi little political situation, I don't know exactly how it works, but everything was towards that plan for 25 years. So everything they did, the budget, everything that was about moving towards that national plan, in 20, 25 years. You're 100% right. So yeah, in Portugal, if you had Portugal 2030, even if you're elected, even if you're on the right, in the center, on the left, you have to.
We've discussed that. We had those negotiations. We defined.
So now your job is to do
that
it.
way. So we are going to
Exactly. Because what happens every 4 years, we have a new election, and then there's a new person that comes in.
Yeah.
It's bizarre.
That's stupid that you throw a lot of money away on work.
We throw a lot of money away on elections.
Why can't we work that way?
No, I fully agree. It is quite absurd. That's why I try to stay quite apolitical, because I think it's absurd what the politicians do to us. I think it's completely absurd.
We can't get apolitical because in a way that everything is politics and we are citizens, and for things to work, we have to make a part of society and participate.
Yeah. No, absolutely. You need to, especially if you're going to campaign. To go in. You don't have to go and rally and join the party and go crazy. Yeah.
Yes. You just have to be a citizen, a responsible citizen with principles. Yeah. And I think we are getting to a very dangerous place with these things like UA coming out of the World Health Organization.
So I say that again?
The US went out of.
Oh, USAID, yeah. Yeah, WHO, yeah, they left, didn't they? Yeah. That was Trump.
So
Trumpism.
We created a lot of consensus after the.
Yeah, we created a lot of consensus, yeah.
The World War II.
We've come a long way from that, haven't we? From the two terrible wars that ravaged most of the world. You know, I've got an interesting little bit of a stat here. I don't know a lot about the healthcare system, but I was wondering, why do we here in Portugal we have this situation with emergency rooms that are overflowing and backed up? According to again that European study, the OECD study, they say that 60 per 100 residents in Portugal, 64 use the emergency room, whereas the global average is only 31 out of 100. So 64 out of 100 people visit the emergency rooms here in Portugal, and globally 31 out of 100 visit the emergency rooms. Why do you think Portuguese people are more likely to go to the emergency rooms? This is an independent report, and you can go verify it with the OECD report. Why do you think it's nearly double?
We're very well prepared.
Sometimes. No, because I was. If you look at all these terrible reports, and it's horrible to see, obviously, but yeah, the reports in Cascais, Sintra, what is that, Amadora, there in Lisbon, where people were waiting 10, 12 for my hernia. I waited 6 hours. Yeah, at Pedro Hispano. I get it. It's not an emergency, okay? So it's dirt cheap as well, so I don't mind waiting. But people are waiting 12, sometimes more. I mean, I come from South Africa. I've seen in Africa, I've been to hospitals in Mozambique, and those aren't hospitals. Those are merely buildings. And I've seen waiting times, I've seen even in some Middle Eastern countries. But the consensus from this report is that way too many people in Portugal are going to the emergency rooms that don't need to be going to the emergency rooms. And they could just be going to get some medication from the pharmacy, or they could just go to their house doctor, Do you have any insight into that? You've lived here for 20 odd years.
Yeah, I have, of course. Probably it has to do with different factors, of course. It's not always
it's not monolithic. There's not just one thing.
There is always complex.
Yeah.
And I'm not a healthcare manager. I've never been very occupied with politics or how to manage.
Because I think this is sociological. Yes,
there are many things. one of them is the access to GPs.
Okay, that makes sense. Okay,
Lots of
because
people go to the emergency room because they have no other way or the place to go.
the other caveat to that research was limited primary care access. So many people have limited primary care access, which means they end up at the emergencies. Okay, that's a good point. Great.
Probably if you compare the primary care network in Amadora Sinintro and in Lisbon, in that zones, is and Machines, for example, we are much better here because we have a network of how do you say centros de saúde?
The health centers,
The health
the health
centers.
Centro Saúde, yeah.
And they are open to emergency cases. Obviously, not to severe cases, but it's not supposed severely ill patients went to the health center. It's supposed to going to the hospital directly. So when I've worked in the emergency department for a lot of years. So, but as an intensivist, I'm more focused on these very severely ill patients. But I've worked previously in the emergency department as an internist, and you have a lot of cases, a lot of situations in which uh, people went to the emergency department because they don't have health literacy.
Health literacy, okay.
It's another important thing. Health education, basic health education, the basic health habits. There's a huge part of the population that remains quite ignorant about
So maybe education would also reduce waiting times.
things like what is a flu, what is
Exactly.
and because they didn't have another backup, they couldn't go to the GP because they don't have a health center, or
They don't have money to go to a private doctor either. That's often the case as well. Yeah. Because even with 64 people per 100 compared to the global average of 31 per 100 who end up going to emergency department visits, you still have a 4% unmet medical need case in Portugal. 4%. So still, even though we have double people that go to emergency departments at 64 per 100 compared to 31 per 100, we still have 4% of the population have unmet medical needs. 4%, and that is, it's much lower in many EU states. I don't have that information, but so it shows that going to the emergency room doesn't necessarily mean you're going to have your medical needs met. You need the primary healthcare centers.
And there's another thing. If you go to a hospital, you are always being seen by a doctor. You can't wait. You can have to wait 12 hours, but you're going to be.
You are eventually going to be seen. Okay.
And that's a kind of a feedback.
Okay, so what you're saying is that no, that's really important, because what you're saying is that if you go to the health center, they might say, come back tomorrow or next week, right? Whereas if you go to the emergency room, you are going to be seen regardless, even if it's 12, 30, 40, 50 hours. You see, those are the type of things.
But sometimes the system is not organized to educate people that way. I guess, for example, in Spain, it may happen, or that is, if you go to an emergency in a hospital and you have nothing very important, or a problem that doesn't need an urgent evaluation, they can send you home and say, no,
But here, no.
But here, no.
So in Spain, they're sending them away.
Okay.
So their data looks a whole lot better.
We're not going to say today, go to your health center tomorrow, because this is not.
Okay, you see, and this is why legacy media is such a pain. You know, CNN and SIC and RTP and all these legacy media. Because when you watch the news. They don't say these things. This is not mentioned. These little nuances are not mentioned. They don't talk about these things. So naturally, Portugal is going to have a much higher emergency room, as we said, 64 per 100 compared to 31 globally. Because in some countries, they send them away and they say, well, you don't need to be here. So these things are kept away from the public to sensationalize it.
You have for example, you have a lot of very dependent patients, very sick, elderly.
Do you have a lot of older parents, patients that live with their children or
That they are dependent on the
children or grandchildren?
yeah
That are dependent on the health system.
or yes on on their families, and there are very complicated situations because these are very ill people requiring a lot of care. Many times they are in hands of families that many times they are not well prepared to understand what's going on, interpret.
So they get stressed, they get a fright, and then they load them in the car, and then they're off to the emergency. Oh, see, all these things are never discussed.
Many times that situations are between health healthcare needs and social needs, and many times the emergencies are flooded with that kind of patients, and it's
That's more of a social
very
issue
difficult to send them home again.
because they don't have conditions necessarily. Yes, I've spoken to nurses who've spoken about it.
Have a percentage, maybe 30% of people in general wards that are in hospital because not because they need healthcare, because they don't have anywhere to go. They are waiting for a nursing home.
Have you ever had cases? Sorry to interrupt you, but have you ever had cases where a patient goes to the hospital just so that they can have a meal, so that they can eat?
Yes.
Can you tell us about that?
Yes.
That is so sad, isn't it?
Yes, in Porto, in Santo Antonio, when I work in the emergencies.
Tell us about that. Can you tell us?
And we had homeless. They came at night and they slept in emergency department.
Nice warm bed and a meal.
We had a few permanent residents at night.
And what do you eventually understand what's happening, right? You know what's
Yes,
happening.
they live on streets.
And you help them, right?
They are alcoholic. They don't have money. And they need a soup or a bed.
Elena, can we chat just before we finish off? Can we chat a little bit about your burnout? Is that something you want to talk about, or can you tell us very superficially, when did you notice your burnout as a doctor? Because I was going to ask some questions about the burnout in the nurses.
Okay.
Because the nurses are often from a social point, But tell us a little bit about when did you start noticing the burnout and what were the sort of the symptoms, and then how did you remedy that?
Well, in my case, I think it was like it was a burnout, and it was a personal crisis.
Okay.
It was not a cute thing. I think
When you say acute, what do you mean by that?
cute. It didn't happen in a few weeks.
Okay.
I think it's a situation that's been dragging me during some years, and COVID had.
Because of the workload?
Yeah.
Yeah.
Yes. After COVID, I had something like a first personal crisis. I started thinking in quitting, in doing some other thing. But I had invested so much
Your whole life, yeah.
in this career that I realized that I didn't know what to do, what I was going to do. Just, I mean, being a doctor is like,
It's part of your identity.
yeah. And
A career that takes over a big part of your life, it becomes very much an extension of who you are.
and now this crisis is deciding to quit of the intensive care was dealing with an identity crisis too.
Okay.
Well, I think it's always an interaction between your the personal traits and the environment. And, and the environment is very stressful. It's very loaded of hard work and emotions and interactions.
The unexpected.
And and yes, I think with COVID was a bad experience. I think uh, I didn't calculate the consequences. I didn't think it was going to be so hard for me.
Because you work many hours and hide in a high and very risky situation.
Many things happened that changed my life. Having to, I was exposed to situations I've never lived before. And my profession, my specialty is always on a red line. You are always on a rush to save people, to decide under high pressure circumstances with limited information. You have to take big decisions. And I was okay with that. But COVID took me to places like that. I think I have some trauma.
You cross the line.
Yes.
On a personal.
For example, things like deciding who to take to intensive care when you have one bed and you have all eight proposals of patients who are not doing well, and you can't take them all because you don't have the capacity to save them all.
So just put that in context. So you've been given the choice, the decision, to make a decision on who potentially could live and die.
Yeah.
Is that correct?
That's part of my job. My job.
Yeah, but it's exacerbated. It's made much worse during
It's a
COVID.
routine for us to decide. We if it's a good idea to send a person to the intensive care because it's intensive in care, it's intensive in damage. To save life, we have to do a lot of damage, and depending on the frailty of the patient, it can be too much damage. And
Are you referring?
it's a difficult calculation.
It's a bit like treating someone with cancer. The side effects of chemo are so rapid and so damaging that sometimes it's even worse than the cancer. Is that what you're referring to?
Yes, it's a different situation because being severely ill means being immobilized in a bed, receiving a lot of medications with a lot of dispositive of catheters and a lot of invasiveness.
It's a very invasive towards the human body.
Invasive, losing weight, losing muscle, because you are in a bed, but
You immobilized.
it's running a marathon because your body is uh, fighting with illnesses and they are very consumptive. So there are a lot of clear cases. If you go to the emergency department with a pneumonia, we'll do everything we have to save your life because you're a young, healthy man and you have physiological reserve.
And was a pretty handsome as well. Definitely worth saving. No, but when you're older, you're not going to make the choice.
An 80-year-old man that
So this is what
never goes out his house because he walks slowly and he's got a few illnesses, and I have to think in that man being.
So this is where you got your red line crossed. So is this what you're referring to? You had to make those type of choices more regularly during COVID.
More regularly, and then medicine was completely dehumanized. imagine we had 21 beds in our ICU and 21 patients with the same disease, and you have to pass to do the round with your colleagues. So patient in bed number 1, 50 years old, diabetic, COVID, ventilation. Next, bed 2, 54 years old, heart disease, COVID, ventilated. Bed number 3, 64 years old, COVID, all the same. It was like an industry, it was like a factory. We at one day we have to create a chart and
Stick it on the wall.
stick on the wall of each patient, describing human things like I am Gary. I like Benfica. I have two kids that I love. Or I am Antonio. I like fishing, because we couldn't distinguish people one from another.
That's insane.
It's insane.
And we see a lot of us in the public.
And then we had to do things like visits were not.
Visits were not allowed, so those people were without their loved ones. A lot of them dying without their loved ones.
I lived things very traumatic, like a colleague of mine handling a phone during doing a call, a video call of a young woman that was standing to say goodbye to the family. Those kind of things happened.
I know quite a few.
Or having to call a family, say your dad is dead.
And they would.
Your mom has gone. Yeah. And it was so cold. It was so provided of absent of humanity. It was so difficult that I think I'm still.
You're still going. I will now never complain about calling a parent, telling them that their child didn't do their homework, because that's a much easier call to make. I will never complain again. Can you just quickly tell me, what do you think covered lab leak for gain of function, or planned lab leak, or mistake? Lab leak. So there's I'll tell you what, I believe COVID was a virus created in a lab in Wuhan, and it came out. I think it was made for gain of function. I think it's very clear that Fauci and his American compatriots were funding that lab, and it leaked out, and the Chinese government tried to keep it quiet for too long, and then it spread, right? What are your views on COVID? It's not wet markets. That's nonsense. That was an excuse, a bad and stupid excuse given. What do you think it is? Do you agree with me?
No.
What do you think it was?
I think was a virus was in nature as many others. Epidemiologists have been warning of us for
that we could be creating
decades.
So you don't think Wuhan was the reason?
I think there are always microbiologists fractions. They are happening all the time in the world, and they are being watched. For me, it's very difficult to think that this is provoked.
Okay. You don't think it was gain of function? No. Oh, it's so much more interesting to think it is. Trust me, I'm going to give you some books. So, before we wrap it up, tell me a little bit about, can you advertise your book club? Are you allowed to? Or is Daniela going to charge me? Can you advertise your book club? Yes. Right? Tell us a little bit about, because they've got a cool book club. These ladies only, right?
Yes.
What about gender neutral? No? Ladies only. Okay.
It's
So
a
tell us.
ladies club, but it's an organic thing.
Okay. So any ladies can join.
Yes.
Okay. How many ladies do you have at the moment?
I don't really know because there's something we have. The club has maybe 30, 40
30, 40 ladies.
Yes, but in a group, in a WhatsApp.
Okay, in a WhatsApp group. And do you meet?
And, really reading books and going to meetings. I guess we are like 8,
Okay.
10.
So the 8, 10 actually that actually do the work.
It's a normal thing.
Okay, and you do this year. You're doing one from 1 month every book, a book from a different country. So you've done January is Ireland, and next month is
South Africa.
and I've suggested Disgrace by James Coetzee, right? Brilliant. John Malkovich
You're
movie.
invited to come.
Oh, I can't wait.
I'll tell you that you are not going to be the first man.
Okay, that's fine. It's fine. Now, if I'm the first man, it's fine. It's fine.
This is a.
No man ever complained about being surrounded by 10 women.
It's something like.
Do you have a name for the book club?
No.
No.
It emerged as from the head of some ladies.
Okay.
Continued with the ladies.
It's great. I think it's fantastic.
But it's not a very.
It makes sense because Daniela's been asking me about these questions about books over the last few weeks. And I've been like, well, what are these questions? And now it makes sense. It's great. It's really cool. Yeah, it's really cool. What's been your favorite book since the inception of this book group? What's your favorite book you've read thus far?
It's been 3 years.
Oh, 3 years, that book, guys. Oh, it's got some stamina, eh?
But maybe Miss Dalloway.
Virginia Woolf. And where can they find the book club? Is that on Instagram? Is there a place that they can follow the book club or join the book club?
No, by now is like a private room.
Okay, so there's no so it's a private Instagram page.
No, we don't have an.
Don't have an Instagram. Okay.
We just have. Okay. It's not a public book.
Okay, so it's by invitation only.
Yes.
Okay. Okay, so
it seems so exclusive.
No, that's good. Keep it exclusive. It's great.
Just a few friends.
So basically, guys, if you're in Portugal, anywhere in the world, get your own book club. Thank you very much, Elena. It's been amazing. Thank you so much for your stories and being open and honest and quite vulnerable. You know, speaking about your burnout and about the decisions you had to make in the hospital. I appreciate it. Thank you very much. Thank you. Bye-bye.